Yeah.
Okay, good. All right. So my name is Ivandito Kuntjoro. I'm representing National University Heart Center, NUH Singapore. However, I was originally from Indonesia. I was born and raised in Surabaya, and I get my basic medical degree in Erlangga University. So it is glad to be back and say hello to everyone. Selamat siang. For the next 30 minutes or so, I'm going to talk and probably discuss with you all about right heart catheterization. Okay, so we a little bit about the history of right heart catheterization, the expanding role of the right heart catheterization in cardiology nowadays, how we do the procedure, and what is the things that we need to pay attention to when we do procedure, and of course some contraindication to perform this procedure. Now I like to go back a little bit about the history of right heart cath. We know that the first cardiac catheterization is actually not performed by a cardiologist. It's actually performed by a urologist, by Dr. Forsman. So basically what he did is basically he put a Foley catheter into his arm through the venous. And of course, you know that when you advance that catheter all the way into the direction of the heart, you will reach the right atrium. And during that time, he proved that he basically can measure the pressure in the right atrium by just putting a catheter. And that's the beginning of everything. Of course, the procedure will then be perfected by this doctor here, Dr. Kernan and Dr. Dickinson. And actually, they both, actually, all three of them share the Nobel Prize for this finding. But if you look at it, 1930, it took almost 40 years before we finally be able to do the right heart catheterization. So the first right heart catheterization, it used to be called a pulmonary artery catheter, was actually performed by these two doctors, which is Dr. William Gans and Dr. Swan. And I think that's where the Swan-Gans catheter name coming from. So the procedure was first performed in San Francisco General Hospital, I want you all to hear the inspiration from Dr. Swan himself about where he get the idea from before he invented the Swan-Gans catheter. So let me play the video.
Watching my kids at the beach, and there was a sailboat. And apparently it comes to the sea, and it had a big spinnaker out in front. So I thought, well, now the probable answer is have a propulsion mechanism, a sail, something like that, a parachute, and stick that on the end of a flexible catheter, and that would work.
That's quite interesting, right? So, you see, this is the principle of Swan-Gans catheter when basically you inflate the balloon at the tip of the catheter. So he mentioned something about having a sail. So basically, it's almost like having a wing on your catheter, which is the function of inflating the balloon on the Swan-Gans catheter. And then what function as your propulsion is basically the blood flow. So basically, the blood flow direction from the right atrium towards the right ventricle and finally to the pulmonary artery is the one that brings your Swan-Gans catheter into that direction. So as Dr. Lucia Cristinati mentioned very thoroughly, that basically usually when you have a patient with pulmonary hypertension, it's always started with clinical suspicion. And and you also look at the clinical risk factor, why they can get pulmonary hypertension. And then in majority of the case, you will start by doing an echocardiogram. But it is important to realize, and this is also mentioned on the ESC guideline, by doing echo assessment for patient with suspicion of pulmonary hypertension, you really cannot make the diagnosis yet. You can only categorize the patient into high, intermediate, or low probability of getting a pulmonary hypertension. And why is this so? Because if you look at the definition of the pulmonary hypertension, You can see here the number defined as having a mean pulmonary artery pressure more or equal than 25. But the next wording is very important, and this has to be assessed by the right heart catheterization. So they do not mention the word echocardiogram whatsoever. So again, the echocardiogram can only give you a suspicion, but the final diagnosis has to be made by the right heart catheterization. And not just for diagnosis, we know that the right heart catheterization is very important in managing the patient with pulmonary arterial hypertension, because we need to monitor the response to therapy. And there's some number on the right heart catheterization that can give a patient, basically can divide the patient whether they have a good or bad prognosis. And also for a patient who's doing very well on the therapy and suddenly they have a worsening condition, right heart cath probably has to be done as well. And why echo is not a gold standard for diagnosing a pulmonary hypertension. So this is the paper that was published in 2013. So basically they measure the number that you obtain on the echo compared to the number that you obtain on the right heart cath as a gold standard. And you can see here the correlation is all over the place. It doesn't matter whether you use a systolic pulmonary pressure, you use a mean pulmonary pressure, you use the left atrial pressure, the correlation is very, very not good. So basically the conclusion of the paper is basically by using an echo, you can only have at most a moderate precision. And of course, this is not good enough if you want to deal with patients with pulmonary hypertension. So again, the right heart catheterization is very important of diagnosing of pulmonary hypertension, and this is considered as a gold standard. But we all have to know that the right heart catheterization indication is expanding nowadays. Right heart catheterization play a very important role in the field of structural intervention, like when we do a TAVI or we do a mitral clip. We always put the Swan-Ganz catheter on the heart chamber to monitor the patient hemodynamic during and immediately after procedure. We can also use to assess the result of the intervention. And one of the things that I found out very useful is actually by doing the monitoring the hemodynamic during the procedure, we can recognize the complication very early on during the procedure. So let's talk a little bit about how we do the procedure. So of course, there's a little bit of variation from one center to the other. But it's important to know majority of the time what we use when we do a right heart cath is what we call a Swan-Ganz catheter. So the size of the Swan-Ganz catheter varies from 5 French, 6 French, and 7 French. In our center, we like to do a 7 French Swan-Ganz catheter. The length also varies from 75 to 100 cm, depend on whether you want to go from the IJ or from the femoral. In majority of the time, we use what we call a triple lumen Swan-Ganz, which has a 3 lumen and one from the proximal, which is connected to the right atrium, one distal connected to the pulmonary artery, and the third lumen is basically when we have a sensor to do a cardiac output. The fourth lumen sometimes can be useful if you have a patient in the medical ICU, because you can use the fourth lumen, the additional lumen, to basically give the medication for the patient. The double lumen is not commonly used because they can only measure, give you the pressure measurement, but you won't be able to do a cardiac output. If you want to do a proper right heart cath and you want to get wedge, the pulmonary capillary wedge pressure, you have to do the Swan-Ganz catheter that has a balloon tip. The newest version of the Swan-Ganz catheter is the one that has a pacing wire, and this one sometimes we use it during the TAVI procedure. So this is the right heart catheterization. In our center, we do it in the cardiac cath lab. And you can see here, usually you can just do it by yourself and then probably just one of the assisting nurse. And then the patient in the supine position, in majority of the time, you do not need to give a patient any sedation, but we always use the local anesthesia. And then this is the monitor of the hemodynamic number that we obtain during the right heart catheterization. And again, in our center, in the majority of the case, we use the 7 French Swan-Ganz catheter, triple lumen with the balloon tip catheter. So in terms of the access and the entry point, there's a few access that we can use. For pulmonary hypertension workup, we usually use a right femoral vein in the groin area is our access. Right IJ was commonly used by heart failure team, especially if you manage the patient in the ICU, because you have to keep the catheter for a few days and you do not want to risk the patient for infection if you put it in the groin. We now try to explore doing the right heart cath from the brachial vein. Of course, if you can visualize the vein nicely in your endocubital, and you can try to do the right heart cath from the brachial vein as well. So this is how we do the access. I just want to make point. I think the most common one that we use is a 7 French, but we're moving away from using a large needle to get access into the femoral venous, and instead we use a smaller needle, what we call a micro puncture needle, which is only 4 French. And we do this under the guidance of ultrasound. You can see here, you can clearly visualize that the needle is actually going and entry into the right femoral venous. And the reason why we do this is just basically to increase the safety of this procedure. We don't want to see any complication. You do not want to accidentally puncture the artery and then dilate the vessel. And it can easily be done if you use the 4 French, because the 4 French is very small. So if you accidentally puncture the artery, you can just easily take out the needle and then just do a little bit of pressing. So I usually like to basically divide the step of the right heart cath into the 7 steps. So the one that I mentioned before is to gain the entry or the access. Again, you can do from femoral, you can go from the IJ, you can go from the arm. And the second step is basically try to push the catheter. Either you go from the SVC or IVC, basically to enter the right atrium. And in majority of the case, this should not be a problem. And then the third step will be trying to cross the tricuspid valve. And then by crossing the tricuspid valve, basically you're going from the right atrium into the right ventricle. And this is sometimes could be tricky, step number 4, in which you basically have to turn your direction upward towards the RVOT. Because if you just keep pushing and pushing, you basically is going to end up in the apex, and a lot of times you get stuck into all this trabecular structure in the apical on the RV. So you have to do some clockwise rotation or counterclock and basically try to push the catheter up. Once you in the RVOT, number 5 is basically trying to cross the pulmonary valve. In the majority of the case, this should not be a problem unless if you have a patient with significant pulmonary stenosis. Once you cross the pulmonary valve, of course, you're going to end up in the pulmonary artery, main pulmonary artery, and then you either can go into the left pulmonary artery or the right pulmonary artery to basically get your pulmonary capillary wedge pressure. So 7 steps of the right heart cath, and then each step has a different difficulty and different step that you need to do. What is the number that we have to get from the right heart cath? This is all the number that we can get from the right heart cath, and I always like to start from the most distal part of the structure, which is get the wedge pressure, and then go all the way back to the PA. Well, we in the mean PA, we usually do a cardiac output by thermodilution. We measure the pulmonary artery saturation, and then go into the RV, right atrial, before you go to SVC and the IVC. This is all the number that will be obtained from the catheter, but some of you are aware that we also need to do some calculation during the right heart cath, and this is what we call a calculated number, which is also very important, which is transpulmonary gradient, diastolic pressure gradient, and pulmonary vascular resistance. I'll go over this in the next few slides. So again, in the right heart catheterization, we like to go from the most distal part, which is the pulmonary artery, to get the wedge pressure, and then go all the way to more proximal. So we get the wedge pressure first, pulmonary artery, right ventricle, right atrium, before we go out. So wedge pressure is actually probably one of the most important number that we have to get when we do a right heart cath. And the wedge pressure is actually is an indirect measurement of the left atrial pressure. And then the recommendation is actually to measure your wedge, not just by getting the mean, but you have to do what we call at the end of expiration. So if you look at this wedge pressure right here, that you always see there's a respiratory variation, and it's always good to get the wedge number at the end of the expiration. And the reason why is because at the end of the expiration, there's a pressure equalization between the extra and the intrathoracic cavity. And then you basically try to get this number at the what we call a functional reserve volume of the lung, and this is considered the most accurate one. And always try to get at least 3 measurements, and then if all the 3 measurements is about the similar number, that you get the accurate number. So as we all know, the normal wedge pressure is between 4 to 12, and everything less than 15 is still considered normal. So again, to be able to get a wedge pressure, you have to hit the balloon. You push the catheter all the way into the most distal pulmonary artery. You inflate the balloon, and if you can see on the illustration here, once the balloon is inflated, so the pressure that you get on the tip of the catheter will be the reflection of the pressure distal to it. And if you remember the anatomy, I put it here, the distal structure, basically the structure distal to the pulmonary artery will be your left atrial. So again, the wedge pressure is an indirect measurement of the left atrial pressure, and this is where you inflate the balloon here. And then once you get the wedge pressure, basically you can basically pull your catheter towards the main pulmonary artery, and then that's when you do the measurement. And don't forget to deflate the balloon, because otherwise you will not get an accurate measurement. And then like when you measure the blood pressure in the aorta, you also get a systolic, a diastolic, and also you get a mean pulmonary artery pressure, as what you can see here. So the mean pulmonary artery pressure on this patient is 32, while the systolic is 41 and the diastolic is 25. So why all this number is important? So the 2 numbers that I mentioned just now is probably one of the most important number, because by getting the mean pulmonary artery pressure, if you have more than 25 or equal or more than 25, then you get the diagnosis of pulmonary hypertension. And then by getting a second number, pulmonary wedge pressure, if everything less than 15, then you have a patient with the precapillary pulmonary hypertension. As compared to when you get a wedge pressure more than 15, then you get all the patient that has what we call a post-capillary pulmonary hypertension. And this is most commonly known as having left-sided heart disease as the cause of pulmonary hypertension. For example, a patient with ischemic cardiomyopathy, EF of 30%, they will have also have some degree of pulmonary hypertension, but this is what we call a post-capillary pulmonary hypertension. I mentioned a little bit about the calculated number. One of them is diastolic pressure gradient, and diastolic pressure gradient you can measure by basically the difference between your diastolic PA pressure minus your wedge. So if it's less than 7, you have a patient with just basically isolated post-capillary pulmonary hypertension. So basically this patient just mainly have a problem with the left side heart disease. As well, when you have a diastolic pressure gradient more or equal than 7, then you have a patient with a combination of post-capillary with a little bit of pre-capillary component as well. And this is the kind of patient which is a little bit more difficult to treat. So, so the measurement of the cardiac output is also important. There's 2 ways to measure the cardiac output. The most common one that we use is what we call a thermodilution. So basically we inject a 10 cc of normal saline, and then we basically look at the machine actually will give us a number. The second number to measure the cardiac output is what we call a Fick method. I don't think you need to remember all this equation. You can just use your iPhone, get a program there. You basically need few numbers. The first number that you need is oxygen consumption of the patient, the hemoglobin, and also the PA set. The AO set is probably just the set that you just measure using your post-ox. But one of the things that I want to mention here, the most common error when you measure the cardiac output using a Fick method is basically the O2 consumption. You assume the number based on the weight of the patient, and this is not recommended anymore. So basically, if you want to get the accurate number from the Fick method, you have to use this device which we use in the cath lab. Basically, every patient that comes, you basically push this indirect calorie meter. Basically, they need to breathe for like 10 minutes, and they give you the number of the O2 consumption for that specific patient. So again, this is very important to reduce the error measurement of using the Fick method. This is how we do the cardiac output thermodilution. You basically inject 10 cc of a saline, and you can see here all the saline will go to the RV, the PA, and then the computer will give you this graph. And then they will measure area under the curve of this graph, and that's where you get the cardiac output. So the larger the area of the graph is actually the lower the cardiac output of the patient. On the other hand, if the area under the curve is small, then the patient has a high cardiac output. And because there's an inverse relationship between the area of under the curve between the cardiac output of the patient. So I mentioned about the diastolic pressure gradient, transpulmonary gradient, and one of the other number that is very important is also pulmonary vascular resistance. Now, Dr. Chris Dinati mentioned that you can also obtain a pulmonary vascular resistance number by doing some calculation on the echo, but I guess the PVR calculation on the right heart cath is still more accurate. And the number was derived by using the transpulmonary gradient divided by cardiac output, and you get the number in the Woods unit. So everything more than 3 Woods unit is considered a diagnosis for pulmonary hypertension, as mentioned here on the guidelines. So PVR more than 3 Woods unit is required for diagnosis of PAH. So vasoreactivity testing, we usually do some kind of a special test during the right heart cath. But again, it's not as commonly done as before. This is basically to assess the patient response to treatment of high-dose calcium channel blocker. For example, amlodipine, but amlodipine that was used before for pulmonary hypertension has to be high dose, like 10 milligrams twice a day. But we only do a vasoreactivity testing now for patients with idiopathic PAH, hereditary PAH, or PAH that's consistent with drug-induced PAH. And the reason why is because only 10% of patients will have a vasoreactivity testing. And then if you commit the patient to receive the high-dose calcium channel blocker to treat their pulmonary hypertension, you basically need to redo this test every 4 months, because in 4 months, 50% of the patient who initially was responded to this treatment will become non-responder. So it's becoming very non-practical to do this right heart cath every 4 months. But again, this is important to know, and this is the criteria that we use. So if a patient has a reduction in the mean pulmonary pressure more than 10 to reach the absolute number more than 40, if there's no significant change in the cardiac output, then basically this is what we call have a positive vasoreactivity testing. I want to just mention a little bit about this special condition called portopulmonary hypertension. We get more and more referral to assess this patient with before they go for liver transplant. And again, the most accurate diagnosis of this has to be made from the right heart cath. We use the criteria of mean PA more than 25, WETs less than 15, pulmonary vascular resistance more than 3 Woods unit. But what's other thing that you have to do when you have a patient with portopulmonary hypertension, you have to put your Swan-Ganz catheter and entering the hepatic vein, as you can see here. And then you basically inflate the balloon, but probably you do not need to do a full inflation. Probably half inflation should be enough, because the hepatic vein sometimes is not that big. And then you basically inject a contrast. If the contrast doesn't spill toward the IVC, then you basically have an accurate measurement. And then you measure what we call a WETs, hepatic pressure. And then when you deflate the balloon, you get what we call a free hepatic pressure. And the delta, or the difference between this, is what we call a wet hepatic, is what we call the hepatic venoportal gradient. So for normal people, the gradient should be less than 5. When the gradient is 6 to 10 is borderline, but everyone who has a gradient more than 10 will be considered clinically significant. Of course, the higher the gradient is, the worse clinically the patient is. If you have see this gradient is more than 20, then this is the kind of patient who usually will present with some kind of pharyngeal bleeding, because the portal pressure was very high. So I'm approaching my end of presentation. So before I end, I want to give some tips and tricks, and also what kind of complication that can happen during the right heart catheterization. So number one, always make sure that the pressure transducer, you zero the pressure transducer. So basically you want to position this transducer in the level of the mid right atrium. because if this precision is wrong, then there's no point of doing the right heart cath. You either underestimate or overestimate the number. So this is the first step that you always have to check. And of course, with every heart catheterization procedure, make sure you have no bubble or blood clot on the tubing system itself, because basically it will interfere with the accuracy of. Number two, we always try to estimate the left atrial pressure from the wedge pressure. In the majority of the case, this will be okay. But for a patient where there's an obstruction either in the lung or in the left atrium, then the wedge pressure is not going to be an accurate reflection of your LA pressure. For patients who have a significant mitral stenosis or significant MR, for the patient who has myxoma in the left atrial, for example, patient who have massive PE, or patient who have significant hypoxia, when you measure the wedge will be significantly higher than your left atrial pressure. On the other hand, if you have a patient with myocardial infarction, patient with the pericardial tamponade, significant AR, or patient with stiff ventricle or severe diastolic dysfunction, when you measure the wedge will be much lower than what the left atrial pressure actually is. So this is one of the conditions that you have to assess and keep in mind when you do this right heart catheterization. So as I mentioned before, the wedge pressure is probably one of the most important numbers that you have to obtain during the right heart cath. And in fact, there's a saying that you should not leave a cardiac cath lab before you get this wedge number if you do a right heart cath, right? So then if you cannot do it with the standard Swan-Ganz, so the other alternative is basically you have to cross the septum. You just cross with a small needle and try to get a direct left atrial measurement. The other thing you can do, of course, you just get a puncture on the arterial and you put the pigtail catheter and you get what we call the LVEDP, which is also a reflection of your left atrial pressure as long as there's no significant mitral stenosis. In majority of the time, the right heart cath is quite simple to do, but I found out that in some patient with a different anatomy, when the right atrial was very large, patient was very obese, sometimes it's not easy to advance the catheter towards the direction of the main pulmonary artery. So what you can do is you can create what we call a right atrial loop. So what you do is it is very important that the loop has to be in the counterclockwise direction. It cannot be on the other way. So when you have this this counterclockwise direction, actually what you can see here, this is one of our patients, you can see here that there's going to be a support on the basal of the right ventricle. And then once you have the support, when you push the catheter, the tip of the catheter will just go up toward the direction of the main pulmonary artery. One of the other things that you can do is you can just also put a guide wire inside the Swan-Ganz catheter. You don't need to push the wire all the way out from the tip. Sometimes just by putting this guide wire, it will stiffen the whole system and it's become easier for you to push the whole catheter towards the direction that you want. This is the trick that I learned in my fellowship. Basically, if nothing else is working, you cannot advance the Swan-Ganz, you cannot do anything else. So what you can do is actually you can just use a normal wire, just 035 wire that you have in the cath lab. You basically try to shape the wire with your hand into this direction. And then once you have this catheter, it's very easy to cross the tricuspid valve. And then once you cross the tricuspid valve, then you basically can put whatever, like just a normal basic catheter that you have, like Judkin right 4 or multi-purpose, to bring the catheter towards the right ventricle, as what you can see here. And once you're in the right ventricle, you just need to flip the catheter into the upward direction, and usually most of the time you can cross the pulmonary artery. Again, not commonly needed, but this is one of the things that is good to know that you can use this trick as well. Sometimes for patient before the right heart cath, you make the patient fasting, they're not drinking for a long period of time, and they become volume depleted, so they are on the dehydration state. Sometimes you need to do what we call a fluid challenge, especially for patients who have a borderline wedge pressure, let's say 14 or 13 and you're not sure. So what you can do is you can just put a 500 cc of normal saline, but you have to do it very fast in 10-15 minutes. Fast infusion, And a patient, when the wedge pressure is going up to more than 15, and this is the patient who we call have a positive response to fluid challenge. And this can happen up to 22% of patient, up to a quarter of patient that we bring to the cath lab. And why this is important? Because as I mentioned before, the wedge less than 15 will bring the patient into the category of what we call a pre-capillary pulmonary hypertension. But when the wedge is more than 15, this is what we call a patient who has post-capillary pulmonary hypertension. And these two conditions have a significant impact on the treatment and prognosis and how we approach the patient. So this is very important. So again, there's not much contraindication, but one of the absolute contraindication to perform a right heart cath is when the patient has a mechanical tricuspid or pulmonary valve, because it is not recommended to leave them open for a prolonged period of time with the catheter. If the patient has a right-sided thrombus in the right atrium on the right ventricle, because you can potentially dislodge that thrombus and cause PE on the patient. When the patient has endocarditis infection, because potentially you can basically cause septic emboli to the lung and other part of the body. The relative contraindication for the patient has a bleeding disorder because you punctured the groin, but again, if you use a thorough puncture with ultrasound, I think the risk is minimized. A patient who have skin infection, bioprosthetic valve on the tricuspid, you potentially still can do a right heart cath, but you just need to be careful. Left bundle branch block is listed as a relative contraindication because sometimes when you do a right heart cath, you can potentially induce a right bundle branch block. So I guess you just need to be careful, because if the patient has left bundle and you cause right bundle, the patient is going to end up with a complete heart block. You just need to be ready. The pacemaker, sometimes when you do a right heart cath, especially in the difficult right heart cath, you can potentially have an interaction with the pacemaker lead. So this is again something that you need to pay attention to. The right heart cath in general is quite safe. I would say the risk is less than 1% to get a complication, but it do happen. The most common complication that we encounter in our center will be the complication around the groin access, such as having a bleeding, hematoma, or vessel injury. Cardiac injury has been described, causing the rupture in the pulmonary artery, causing the perforation on the right ventricle, especially if you have a patient with dilated RV and has a scar. But again, this is rare. If you put the wedge, if you wedge the pulmonary artery for a prolonged period of time, potentially you can cause a pulmonary infarct. Arrhythmia, I would say, is quite common, especially if you put your catheter in the RV, the patient can go into VT, but once you position the catheter, then the VT usually will resolve. Thrombus, again, can happen if you leave the catheter for a prolonged period of time, and of course, infection. But I guess from all this complication that I mentioned about, the most dangerous complication from the right heart cath, if you get a wrong data. So if you get a wrong data during the right heart cath, you don't do it properly, it will end up with the wrong diagnosis and treatment of the patient. And I guess this is the most dangerous complication that you can cause when you do a right heart cath. Now, before I end my presentation, I would like to acknowledge this Dr. Michael Regasta. He's one of my mentor during my fellowship. He's the one who teach me how to do a proper right heart cath, how to interpret the hemodynamic. And for all of you who has an interest in this, I would recommend go try to read his book. It's very easy to read. He has a second edition, and I think it will help you a lot with how to interpret the hemodynamic on the right heart cath. With that, I would like to say thank you very much for your attention, and I leave my email here for any of you who probably have a comment or you want to discuss further. Thank you.